Thank you, Greg. Thank you, everyone. So let's open this up to questions. I have a couple of my own, but let everyone start asking questions.
Hi, Larissa Neklarov, a general internist from Boston. My question is for Dr. Barron. So in your remarks, you focused on what ABIM is doing in oncology certification examination. I'm wondering what the ABIM is doing for general internal medicine certification. And the second question is it time to revisit a survivorship subspecialty, sort of a la palliative care?
Thanks for the question. I'll take the second one first. There's certainly a lot of value to creating a discipline. It focuses research, it focuses training, it focuses energy, but there's real limitations in doing that. It's a specialty care model for a problem that you'd like to have capacity for dealing with diffuse throughout the delivery system. So I think that's a decision that the field will basically make, but as a general internist, I'm more sympathetic to the idea that we would expect that as a core skill across people doing healthcare. With respect to what ABIM is doing in general internal medicine, I mean, generally what we're doing across the board for all of our assessments is doing them much more in partnership with the community and much more focused on the idea that maintenance of certification really is different from the initial credential. The initial credential says that you're ready for unsupervised practice. But over the course of the career, the credential really needs to speak to, are you staying current? And I'll admit that one of the ways we got into trouble was we weren't very clear about that, but we're being increasingly clear about that now and moving toward more frequent assessments that can be integrated in practice with the idea that as much as doctors hate a 10-year exam, it's hard to defend that waiting 10 years to check on somebody's continuing staying current is not a good plan.
So I just wanted to clarify. So with the MOC, I mean, so are there questions, are there modules that are being developed for internal medicine recertification to focus on survivorship, surveillance, late effects, et cetera? And then back to the original question, which is, you know, the same idea can be said for palliative care, that you have the specialty, but really palliative care has to, you know, lie across the board.
So it's a great idea, and I think if they were going to be developed, the expertise would be in the ASCO and oncology community, and our role would be diffusing it across the discipline by making it available and recognizable by any physician who is doing it. And I'm happy to talk to you more offline about it.
Thank you.
Hi, my name is Eric Vinson. I asked a couple questions yesterday. I have a comment and a proposal. First is a comment that I hope that all of this information and knowledge can be disseminated, implemented to reduce the disparities of cancer survival for American Indian Alaska Natives. If any of you looked at the 2017 annual report to the nation, you'll see that American Indian Alaska Natives have the lowest survival rate of all races. That's my comment. My proposal is, we've talked about EHRs, and I know Larry's comment about that's a whole nother workshop, but if there could be a consensus statement from all the different organizations here as well as elsewhere to the vendors to say this is something we have to have, because in my experience in talking with different facilities, every facility is fighting this fight to get their vendor contract to implement the basic information that we're talking about that's taking maybe 5 minutes if you've got an awesome program like Dr. Mayer's, or 30 to 90 minutes if you're in a community setting. So that is something that every facility is fighting for. And if we could all come together with a consensus statement perhaps, or whatever mechanism you think, and then to also consider the primary care settings, because those electronic medical records are even further behind. I am not even aware of a primary care one that includes survival. And so if that could happen, then that's one less barrier that, like Regina was talking about, that we have to address, and we can focus instead on the patient and the patient care. What do you think about that?
Eric, thanks. I would just make one EHR comment. I was afraid to go down that road, but there are a number of programs, and Deb's is one, that have figured out facilitated ways to use EHRs in spite of the company they buy them from to produce plans that are easier for the practitioners, take less time, incorporate, import is the right word, import all the demographic data, a lot of the treatment data, and so on. And what we don't do as a profession is we don't actually share what different programs have worked out, so that we've got all these programs working in silos and isolation without sharing what they've learned. And so maybe that's something that this workshop could ask people and follow up to figure out how to do.
I'm just going to put in a quick, I'll go ahead and speak. I'm just going to put in a quick word for the oncology care model. So I always joke this, nice being the richest guy in the room, $800 billion in my pocket. The oncology care model requires a survivorship care plan, and EMR vendors are now working on survivorship care plans because it's a requirement of the model. Similarly, the 13-point IOM care plan is a requirement of the model, and EMR vendors are incorporating that into their vendors. So sometimes money talks.
The other thing, where are you? There you are. EMRs, as you know, are for billing, not for care, which is a problem in and of itself, and that has to be fixed by the customers, who are primarily providers and hospitals. In my research for this session, I came across a number of articles about creative ways one can use existing codes to get survivorship care and counseling paid for without having a code that says survivorship care and counseling. That's what needs to be automated into these systems, so that not every doctor and every hospital has to come up with their own magic formula of how to get paid for their time. They need to look at the models that people have generated that work, that also don't lose them money in terms of the time and people involved. They actually break even or even make a little money using the proper codes for visits with people who are providing survivorship care and counseling. So if to the degree we can automate that, it takes all of the pressure off the doctor to figure out, I want to do this, how do I get paid for it? And that's one of the best functions of the EMR system, is to make that easier for doctors. The other issues with the EMR system is going to be a much bigger, longer row to hoe, as we say in Arkansas, where I'm from. But we're hoeing it, and we're going to see what we can get done. I just one light anecdote. When we had a meeting with Epic and Cerner and all the big dogs in EMRs when we were still in the White House, and Vice President Biden was asking Judy from Epic, why can't I get my medical records from you fast and cheap? She said, why do you want them? You don't understand more than the first 10 pages. Why do you want a 1,000-page medical record? Which I was really hoping she wouldn't ask him. And he answered the way we all should answer, which is none of your business. None of your business. If I want to nail them to the walls in my house, I'll do it. But that's not your business. I'll figure out what to do with them. You just make them available. We're so far from that, but we're working on it.
Brandon, do you want to?
Well, just to kind of echo on that last point, I mean, fundamentally, that raw data should belong to the patient. And if every institution is spending all these millions of dollars to customize their own EHR, if they took a fraction of that and said, let's customize a universal patient platform, I think it would solve a lot of this communication barrier.
I'm just going to add real quickly, because we deal with data blocking issues in the oncology care model, and the 21st Century Cures Act actually outlaws data blocking, and so it's, I guess HHS is designated with writing a rule for that. So that is, I think we have 12 months to write the rule, which is fast work in government terms, so we're doing that. Go ahead. Question.
Hi, Adams Dudley from the University of California, San Francisco. I'll tell you what I'm going to propose, then why. So I'm going to propose that NAM host a day in which we focus on the payment issues that have been brought up so much in this last panel. And we actually, I'm now speaking mostly to the patient advocates, please come. So I do payment policy all the time, and the patients are never there. And that leads to payment systems where your issues are not the focus of payment, and therefore you hear stories like you've heard today. So I'll just now go through the stories. The last 2 days we've heard all sorts of clinical needs not met. From Susan, we heard that there are nurses ready to do that, but not allowed to do that. From Lori, we heard that the places that get great survivorship programs are the ones that have some source of funding. You mean philanthropic funding, right? Yes. So the payment system for care does not provide the money that makes those systems happen. From Brandon, we heard that he'd been working at a bone marrow transplant program for many years, and it was only when the public reporting measure became 3-year outcomes that they were willing to begin to think about changing their resources, and then quickly did, in fact, change their resources available to focus on the 3-year outcome. What this set of stories says collectively is there are a lot of needs not being met, and the last points are saying it's because of the way we pay for care and the way we create reputational incentives, which is what that public reporting thing is. So, and it's really organizations that in the end have to make this happen. You can have a great clinical champion, but one person alone, if they're fighting the system, that's a much harder job, and it's not going to lead to solutions. So I think that the next, and a key next step for us would be to bring lots of patients into the room to define what it is that should be measured and rewarded, and then have with them the oncologists who currently aren't doing the survivorship care to say why they're not doing it, why they're skeptical about that, and then people who are experts in payment to say, well, if these are the things that we can get those two groups to agree on, then how would you build a payment system that would do that?
Ask one last question, and then I'm going to wrap up. And I'm sorry, I went the wrong side. I didn't realize you're sorry.
Thank you. Jean Rosiak. I'm a director on the Oncology Nursing Society. I'm also a nurse practitioner in Milwaukee, Wisconsin, in a breast center. And as an advanced practice nurse, I think a solution is standardizing scope of practice, educating nurses. I know in some areas in Wisconsin, my hands are tied as far as what I can recommend and prescribe. For instance, I have to have co-signatures on ordering PT or rehabilitation services. Standardizing this, Wisconsin is not one of the worst states for this, so I think that is a solution. Education of nurses, incorporating survivorship care, oncology care into basic education is essential and would be helpful. Who better for survivorship and communicating with patients? We touch every aspect of their lives. Another more personal area, we spoke much of caregivers and the FMLA. I think a change in that. I had 2 sisters who died of horrible illnesses, required a lot of care, and I was shocked that I couldn't take off work to take care of them. So had to either lose my job, use my vacation, or intensely coordinate care for those 2 women who did not survive. I think everybody here mostly has siblings, and can that be changed?
Thank you. I'm going to take the last 2 minutes and wrap up, and then I'll let Patty do the day and a half wrap up. I'm just going to do a little wrap up. So somebody said we want marching orders coming out of this workshop. What do we have to do to make things better? So appreciate the first day spent all about looking at the evidence and some of the problems. We spent the first part of today looking at models, successful models that adapt in different kinds of work environments. And then we just spent the last, I guess, hour or so, hour and a half, talking a little bit about other problems. So from Dr. Barron, doctors need to keep up, whether that's a proctored closed book exam or whether that's CME or whether that's small little mini tests is to be decided. But doctors need to keep up on terms of oncology, be supportive of that. From Brandon, we're going to make preservation of fertility a benefit, an essential health benefit. No, he didn't say that. But obviously, I think fertility preservation is important. That's something certainly we do in pediatric oncology. We're much better at doing that for men than we are for women. But I think we're making technical progress for women. From Lori Eisenberg, we have band-aiding survivorship care plans. We have building centers and supporting them, however we do that financially. For Rebecca Kirsch, we have supporting care giving. We have a variety of pieces of legislation that we heard about yesterday that would support that patient-centered care. Patient-reported outcomes, which I'll say again, are an oncology care model, and one of the definitions of how much you get paid as a performance-based payment is how you do on your patient-reported outcomes. From Larry Schulman, accreditation and supportive of that in survivorship care plans. From Susan Schneiderman, a lot of recommendations: funding, research, more clinical faculty, survivorship curricula. I will tell you that my daughter just finished nursing school, and in her unnamed nursing school, she was learning what a grain was, which is a 19th century measurement of units. But so we can take that out and put in survivorship curriculum. And then I think from Larry, we were talking about Larry, and then from Greg, I think just in terms of things we can implement and just finding codes for how we provide survivorship care, because unfortunately money works in terms of making things happen, but certainly a whole bunch of other things, making friendly environments for survivors. He was not, just to clarify, he was not recommending that we get stoned before we know. And just a whole bunch of different things in terms of how we do that. Thank you very much to the panel. And you now have marching orders, so when we come back in 10 years, this will all be done and we won't have to do this again. Thank you very much.